Good afternoon, everyone, and thank you for joining us for today's webinar, Futures Without Violence, Assessing for Intimate Partner Violence in the Primary Care Setting. My name is Rachel Logan, the Training and Technical Assistance Manager at the National Center for Health and Public Housing. We are joined today by Johnette Payton and Sarabi Kuke. At the National Center for Health and Public Housing, we offer free forms of training and technical assistance to those serving low-income populations. That is in the form of webinars such as this, manuals, toolkits, and other resources that you can find on our website. Our speakers today will discuss issues related to addressing the needs of those in abusive relationships or those who are being abused and how we can assess those at the primary care level. After today's webinar, attendees will be able to list 3 health effects of experiencing domestic violence, use resources that are tailored for assessment of domestic violence in the primary care setting, and also describe local domestic and sexual violence programs to support patients who disclose abuse. Our first presenter is Johnette Payton, who is the Health Promotion Project Manager at North American Management. She is a certified health education specialist and has an eclectic background which blends sociology, criminal justice, and public health. Sarabi Kuke has worked in the field of women's health and human rights for 15 years. She is based in Austin, Texas, where she is the Director of Prevention Programs at the Texas Council on Family Violence and has led statewide efforts to improve the public health response to intimate partner violence. I will go ahead and turn the presentation over to Johnette.
Thank you, Rachel, for such a great presentation. My name is Johnette Payton. I am the Manager of Policy Research and Health Promotion here at North American Management. And what I will be discussing is an overview of intimate partner violence. So basically, I will talk about some of the risk factors associated with it, and then I will also just kind of talk about some of the medical recommendations, and then I will turn the presentation over to the next speaker. So just to begin, some of the health effects that can be experienced by those who are victims of domestic violence include scratches, broken bones, having trouble sleeping, depression, suicide, and panic attacks. So as you can see, victims of intimate partner violence, or IPV, suffer from a variety of physical effects that can be either physical or emotional. So I just want to start off with a quote from the National Institute on Justice that states that violence against women in intimate relationships occurs more often, was more severe, and was more likely to be repeated in economically disadvantaged neighborhoods. And this is something especially important to note for the providers that we work with and some of the advocates, because we do work with health centers that do focus on low-income or economically disadvantaged populations. So the definition of IPV can vary depending on the setting or the survey parameters. On this slide, I provide to you the generally accepted definition, and I won't read that to you, but I will say that the Family Violence Prevention Services Act was amended in the 1994 Violent Crime Control and Law Enforcement Act to support the work of coordinated community responses. And in 2010, this act was reauthorized in order to fund state domestic violence coalitions for the purpose of funding and supporting local efforts to prevent intimate partner violence. On this screen, I'm showing you the different types of violence that some victims can have occur to them. The different types include physical violence, sexual violence, and I provide examples of what falls under each one of those categories. There's also threats of physical or sexual violence, emotional, psychological violence, and stalking. And with stalking, I did want to just kindly briefly define that because there can sometimes be confusion on what is considered stalking. In some states also, stalking may not fall under the IPV protections. So stalking generally refers to harassing or threatening behavior that an individual engages in repeatedly. Stalkers may be motivated by a desire to exert control over their victims. Next, I wanted to talk about survey results, some of the major survey results related to IPV from the National Institute of Justice as well as the National Violence Against Women Survey. So to begin with the NIJ-funded studies, it was found that intimate partner violence is more likely to occur when couples are under financial strain. They also found that concentrated disadvantage or economic distress was very highly correlated with women experiencing violence in intimate partner relationships. They also found that having few economic resources affects a woman's decision to stay or go. And sometimes the thought of losing financial support may outweigh the fear of the violence that they are experiencing. And with the National Violence Against Women Survey, they found that Asian Pacific Islander women and men report significantly lower rates of IPV. But what they speculate is that some of these differences may be due to the willingness of the partner to report IPV. And with Asian values, they discussed how they emphasize close family ties and harmony, which may discourage the reporting of IPV. Next, I wanted to talk about some of the perpetrator risk factors. And I did just want to remind everyone that a perpetrator can be male or female, although it generally is more likely to be a male, but there are females who are the perpetrators of domestic violence. And as you can see, some of the examples include early fatherhood or being raped at a young age, and also experiencing a violent event at a young age. And one of the really important ones is the last bullet, which states not having a job or other stressful events. Next, I wanted to talk about some of the victim risk factors. And again, just to remind you that a victim can be male or female. They can be in a heterosexual relationship or a homosexual relationship. And with some of these studies, they found that women who had children by the age of 21 were twice as likely to be victims of IPV. They also found that lower income was correlated with higher rates of IPV. And there are some studies that also found that reductions in AFDC benefits were associated with an increase in intimate partner homicides. And because I know many of the populations that we work with can be in economically disadvantaged neighborhoods or ethnically diverse neighborhoods, studies found that IPV can affect the woman's ability to find employment. And when I talk about the diversity, immigration status may also affect the woman's dependency on her abuser. Next, I just wanted to provide a reference slide to you on the various costs of IPV to society. What authors found that the costs have been underestimated because it does not include the criminal justice system costs. And with the last bullet, women who experience severe aggression by men are more likely to have been unemployed in the past, have health problems, and be receiving public assistance. They found that this included not being allowed to go to school or work or having their lives or their children's lives threatened. So just quickly, this is something that has been outlined in Healthy People 2020, and it also was outlined in Healthy People 2010. And if you're interested in more data on this, a potential data source can be the National Intimate Partner and Sexual Violence Surveillance System. So just to talk about some of the recommendations for providers based on some of the larger organizations, the U.S. Preventative Services Task Force does recommend that clinicians screen women of childbearing age for intimate partner violence. They found that effective interventions can reduce violence, abuse, and physical or mental harms for women of reproductive age. With the American Medical Association, their recommendations with regards to intimate partner violence is they support physicians having a routine assessment of all patients for symptoms of violence and abuse, not just those ones that you suspected in, but just doing it across the board because sometimes some people may be able to hide that very well. They also feel that it's very important for medical schools to provide training on violence prevention for physicians. And one thing to remember is that physicians must assure patients that the information shared will be held in confidence, but it is subject to the legal reporting requirements of that state. Lastly, I just kind of wanted to talk about the Institute of Management recommendations. Again, they recommend that this should be a covered screening and that it is something that can actually help to reduce the number of women affected by intimate partner violence. So now that I've discussed screening, I will turn the presentation over to my co-presenter, who will go into more detail on screening and instruments that you can use to help assess intimate partner violence. Thank you.
Well, hello, greetings. Again, my name is Surabhi Kuke. Thanks so much, Janet, for that overview and introduction. That was super helpful. I will be talking today a little bit more in depth about identifying and responding to intimate partner violence and a sort of specific aspect of intimate partner violence called reproductive coercion. As Rachel mentioned earlier, so these are just the learning objectives. Just want to put it out there for y'all to kind of register. Just to give a little background on Futures Without Violence, we're a nonprofit based in San Francisco that has been working on violence prevention for over 30 years now, and covers a range of issues beyond healthcare, including legal advocacy and a whole variety of issues. And I invite you to check out the website. It's quite robust and with a lot of information, but I just wanted to give a little background. And one of the projects of the Futures Without Violence is the National Health Resource Center on Domestic Violence. So for those of you who are healthcare providers and either run or work at in clinical settings, we really encourage you to check out what is available in terms of posters, guidelines, safety cards, etc. And I'll be going in depth today about a couple of these tools. Just to give you an overview, the information I'll be presenting today is part of a national initiative called Project Connect, which really tries to foster relationships between folks working in public health and people working in domestic violence or violence against women, which is what VAW stands for. And so the key components of this program is really focused on clinic-based interventions, bringing health services into domestic violence programs, thinking about state-level efforts to shift policy, both in terms of data collection and analysis and change, and then thinking about sustainability and how to integrate it into existing infrastructure through evaluation and other forums. So this has been going on for about 4.5 years and is operating all throughout the country, and these are the studies that have emerged from this work is a lot of the foundation of what I'll be sharing with you today. So in addition to the AMA guidelines that Janet mentioned, I just want to draw your attention to a couple of other places that really build support for addressing IPV. And when I say IPV, I mean intimate partner violence, which is sometimes used interchangeably with domestic violence, which we recognize are actually very different. They have different meanings. IPV is a much broader concept, but you'll see both of those terms as we go forward. So the American College of Obstetrics and Gynecology had submitted an opinion paper on intimate partner violence indicating that it was best practice for providers to screen for violence. Planned Parenthood has made it part of their standard of care. The Affordable Care Act, it reimburses for domestic violence screening as part of preventative health services. So there are a variety of different federal and national efforts that really support this work. So you all are kind of well positioned and well supported to be going forward with thinking about how to respond to IPV. I also want to really appreciate the way Janet broke down racial disparity and in particular the vulnerability of low-income women. We know that in reality, violence doesn't discriminate, but in reality, meaning in the abstract, that anybody can be violent and anybody can be victimized. But in reality, the sort of vulnerability based on identity or social marginality really does make worse a situation that may be bad. So, you know, if there isn't economic stability, vulnerability to violence or staying in a violent situation is made worse, and so forth. So we just want to recognize, I'm not going to go into a lot of data on this, but you know, we know that 1 in 4 American women are have a lifetime experience of violence, and that's 1 in 5 teen girls. And with proportions like that, it's sort of incumbent upon us as social service providers, health service providers, to take a good look at the women clients and the women patients that come in through our doors and really think about how their relationships might be affecting their health. So I want to invite you to do a really quick poll. It's not clear to me how many folks are on right now, but I think it's somewhere in the ballpark of 100. Can you think of a time when a client that came to you, their health symptoms or something that they indicated about their health made you suspect that there was a problem at home, but neither you nor the client said anything? I'm going to ask Devin to go ahead and share that poll with all of you. And Devin, I'm not sure if I'm going to get to see it, but let me.
Sorry about that. The poll is up.
Okay, great. I'll just give it a few more seconds, and Devin, maybe you can sort of tell me or chat across what the results are, because I'm not able to see it.
Results are still coming in. Give me a couple more seconds.
Great.
And they seem to even out now.
Okay.
Let's see. So we have 36% yes, 27% no, and 36% unsure.
Okay. Thank you so much for responding. I think that it's so helpful to hear that kind of honest response, because what we see often, both in the clinical setting and in the advocacy setting, is that there's a lot of confusion. I mean, those of you who honestly expressed that you were unsure, it really could have gone either way. It might have just been she got in a fight with the bus driver on the way over to the clinic. You know, you don't know exactly what's going on, but the point is, not knowing also creates these worries, anxieties, or barriers to actually asking. So some of what we've uncovered through the research and practical work around the country is that clinicians and other kinds of service providers identified a number of similar barriers about talking to patients and clients about their violence. First, and above all, typically providers will say, oh, this isn't my job, whichever kind of provider it is. This part isn't my work, and there are other people who know this better. And to some degree, that's true. There are experts in the field. But we're learning more and more that people who work within the health system and in social service really have an opportunity to ask a simple question that's not invasive, but is like a doorway into figuring out what kind of referral a woman needs. People refer to not having enough time, and I'm going to show you some approaches that take very little time and hopefully will be useful. Comfort levels, and now this is something that can only be tackled through practice, so I would invite you to just give it a shot and keep trying until you feel more comfortable. Not knowing what to do about positive disclosures. This might be the single most commonly articulated barrier, that I don't know what to do if she says yes, so I don't really want to ask anyway. And, you know, I can't say enough about making referrals, but we'll go into that a little bit more detail. And then this is a really real phenomenon, and certainly it results in a lot of frustration and even burnout for providers, but just those feelings of frustration when a patient either doesn't follow through with their fulfilling prescriptions or adhering to whatever protocol that you've administered, or they don't follow through what you talk about if you actually have a conversation. When a patient sort of goes back to the abuser, that can be really demoralizing for a provider and make you feel like, I don't even want to try. But I hope that what I share with you today kind of helps broaden these barriers and to be able to address them with a little more clarity. So to simplify this process, we are talking about universal education. This way you don't actually ever have to identify if anybody is experiencing it. If you can hand a safety card, which I'll be sharing with you in detail, to every woman that walks into your center, whether it's a clinical setting or a other kind of service provider. Just provider education on the connection between violence and health has shown itself to be extremely helpful for women to be able to even identify the ways that their relationship is affecting their health and the choices, the opportunities they have to make choices to shift that. And connecting intimate partner violence and reproductive coercion and health risks to the visit type. So if she's coming in for contraceptive counseling or an STD screen or a pediatric visit, there are simple ways to connect the screening question to the visit she's coming in for, so it doesn't feel out of the blue or just like a checklist question that you may have had to do, in a variety of settings. The safety card intervention that I'll be sharing with you is a beautiful simplification of this this kind of screening and assessment, and then really using strategies for referral and support. So you do not need to become the expert on domestic violence, intimate partner violence, and safety planning and lethality assessment. There are experts who are available 24/7 to do that kind of work. But getting really clear about who you can talk to, who you can send her to, and how to get her there safely is going to be your best resource. And so I'm here to tell you that you as providers can make a difference. Our research shows that women who talk to their healthcare provider about abuse they're experiencing were more likely to use an intervention. And by intervention, we mean whether it could be just calling a hotline, it could be seeking counseling, it could be taking her children for counseling, or it could be something more drastic like seeking shelter at a domestic violence shelter. But their likelihood of using an intervention is really rich because it tells us that the isolation got broken. The single most harmful thing that gets multiplied by all of these other forms of abuse is the isolation that women feel in abusive relationships. Like she's the only one, nobody cares, and in many times the abuser will prevent her from connecting with people she loves, her family and her friends or healthcare providers or other providers. The other thing we learned is that they're more likely to exit an abusive relationship. This kind of information is not what we were looking for. We're not in the business of trying to get people to leave their relationships. But when things get bad enough, it has been shown that having a trusted authority figure like a health care provider talk about healthy relationships can make a difference in women seeing their relationship as healthy or unhealthy and making choices based on that. I want to take a few minutes to show this little animated video clip that really outlines reproductive coercion in a simple way so that you can think about identification and response. 2 seconds.
Making the connection, an integrated response to intimate partner violence and reproductive coercion, is an innovative educational series created by Futures Without Violence. While the term reproductive coercion is relatively new to the field, the connection between violence and poor reproductive health outcomes has been well documented across disciplines for the past 25 years. Reproductive coercion involves behaviors that a partner uses to maintain power and control in a relationship related to reproductive health. Dynamics include birth control sabotage, pregnancy pressure, and pregnancy coercion. Birth control sabotage is active interference with a contraceptive method by someone involved in an intimate or dating relationship with an adult or adolescent. Dynamics include hiding or destroying birth control pills, intentionally breaking condoms, and removing contraceptive rings or patches against her will. Pregnancy pressure involves behaviors that are intended to pressure a partner to become pregnant when she does not want to be pregnant. These behaviors may be verbal or physical threats, or a combination of both. Examples of pregnancy pressure include, "I'll hurt you if you don't become pregnant," and "I'll leave you if you don't become pregnant." And pregnancy coercion, which involves threats or acts of violence if a woman does not comply with the perpetrator's wishes regarding the decision of whether to continue or terminate the pregnancy. Multiple representative studies demonstrate that at least 1 in 4 women has experienced sexual or physical violence at the hands of her partner. In family planning settings, prevalence rates are even greater. In fact, the incidence of physical and sexual violence can double. As many as a quarter of women coming to family planning clinics report that they have experienced reproductive coercion. By defining reproductive coercion, we have a lens to understand this very specific and common form of abuse. This knowledge transforms the role of healthcare providers and the way in which they can help women prevent unwanted pregnancies and STIs and promote their safety. Recent evidence has shown that a brief intervention for reproductive coercion reduces the likelihood of pregnancy coercion by 71%. Women who received the intervention were 60% more likely to end a relationship because it wasn't healthy or unsafe. In this series of modules, we will show examples of ways providers can address reproductive coercion, providing language, tools, and techniques for effective intervention, changing the standard of care, and in doing so, changing women's lives.
Okay, thank you. So just to backtrack a tiny bit, defining reproductive coercion, we're talking about behaviors that a partner uses to maintain power and control in a relationship that are related to reproductive health. Earlier, Jeanette mentioned very accurately that both men and women can be victims of intimate partner violence. And in this case, it's largely women that we're talking about. That's not to say men can't find themselves in situations where they're manipulated into parenthood. That does happen, I know. But for the purposes of this discussion, this presentation, I just want to clarify that I'm speaking mostly about women who are victimized and in the context of heterosexual relationships, just because we are talking about women's health and reproductive coercion right now. So just as that video mentioned, we're talking about explicit attempts to impregnate a partner, controlling the outcomes of a pregnancy both in either direction, either forcing a woman to keep a pregnancy or forcing her to terminate, coercing unprotected sex, interfering with birth control methods, also called birth control sabotage. Now, one of the data points that they shared in that video is that nearly over 1 in 2 women who come to family planning clinics report reproductive coercion. And part of the reason why I wanted to really bring this up with this group, because of who you work with, is that what we know about family planning clinics nationwide is the population that uses it are predominantly low-income women, and that the fact that there is such a high proportion of experience of reproductive coercion in this population raises a lot of red flags for all the kind of attendant resources that are available for the women who attend these kinds of clinics. So there are so much overlap that it's really worth noting that even though the national standard is 1 in 4, for women who use family planning clinics, particularly in their reproductive ages between 16 and 29, the rates go up to 1 in 2 when we're talking about reproductive coercion and intimate partner violence. So it's just to kind of put that in perspective for the populations that you work with. I'm getting a note that you may not be able to hear me. I hope that this is audible, and please somebody give me a sign either in the chat box or otherwise that it's not.
No, you're fine.
Okay, great. Thank you, Rachel. So just some of the qualitative data. This is to illustrate the way that even in long-term relationships, sexual violence presents itself. For instance, this young woman says, "I'm not going to say he raped me. He didn't use force, but I would be like, no." And then the next thing, he pushes me to the bedroom, and I'm like, "I don't want to do anything." And then we ended up doing it, and I was crying, and he still did it. And then after that, he got up, took a shower, and I just stayed there. You know, if we were able to be doing this training in person, I would ask, was she raped? And I know that the vast majority of you would say, well, yes. And we could have a discussion about the stigma related to rape. But the reality is, within relationships, violence occurs in all kinds of subtle ways. That's why when we talk about domestic violence, we're talking about patterns of coercion and patterns of control. And coercion and control with regard to reproductive health is one of those places that really healthcare providers are some of the few people that can actually ask about it, because you have a reason to ask about her reproductive health. We know that intimate partner violence increases women's risk for unintended pregnancies. Adolescent girls who are in abusive relationships are far more likely to become pregnant than non-abused girls. So in the context of our teen pregnancy rates in all of our communities around the country, to really take a look, before we talk about condom education, to really take a look at the extent of violence in those relationships, to ask a question about, do you feel like you ever feel like somebody makes you do something sexually that you don't want to do? Do you feel like you can say no? Do you feel like anyone messes with your birth control? Some simple questions that can actually facilitate a conversation before saying, just use a condom, or assuming that knowledge is enough. A quarter of adolescents reported that their abusive male partners were trying to get them pregnant. Here's where we talk what the video talked about, pregnancy pressure, a form of reproductive coercion, trying to convince women to get pregnant and stay pregnant as a way of controlling them. That is a huge proportion if we think of all the adolescent women who are coming through our doors. And then to reiterate what I just said, knowledge is not enough, and I think Janet mentioned this too. You know, when we're talking about either economic stability, you know, access to resources to live our lives, or the threat of violence, a woman might choose the threat of violence. Similarly, when we're talking about risks of HIV or STI infection and the threat of violence, even if she knows how to protect herself and routes of transmission and how to keep safe, she might choose to allow her partner to not use a condom, for instance, because she's afraid of the threat of violence. So fear as a factor in the dynamic can radically impact the health outcomes of your patients and clients. Again, this kind of goes back to my earlier point. Before we start talking about condom education, it's worth checking in about whether or not she feels safe asking about using condoms. And then just to touch on something that was already mentioned, but to go into a little bit more depth, women who experience past or current intimate partner violence are also more likely to have more sexual partners at the same time, have a past or current sexually transmitted infection, report inconsistent or non-use of condoms. Again, this is related to the point I just made, not for lack of understanding. You know, we should never assume that she just doesn't get it or she just can't remember. If there's a patient that's coming in with repeated STIs, patient coming in repeatedly for emergency contraception, or the most blatant version, which is adolescent rapid repeat pregnancy, or even any women, not just adolescents, rapid repeat pregnancies, it's worth asking, was this a planned pregnancy? Do you feel like you had control over your birth control? And then women who experience IPV also are more likely to have a partner with known HIV risk factors. So this intersection becomes, increasingly more lethal. And we can't underestimate or understate the ways that poverty and discrimination, sort of larger institutional discrimination, affect women's ability to negotiate power in sexual or other relationships. So I'm just going to sort of repeat that periodically because the studies show it, and your experience as providers in communities with low-income populations certainly, I'm sure, reveal this, but it's a factor to continue to keep in our minds as we think about these kinds of assessments. So the flip side around birth control sabotage is around male partner pregnancy intention. So condom manipulation, like the first couple of times the condom seems to break every time, 6 times. 6 condoms is kind of rare, etc. And she hears him say, he was always like saying, you should have my baby, you should have my daughter, you should have my kid. So this kind of pressure is subtle. He may never have laid a hand on her, but it really presents itself as a way of preventing her. And this young woman actually wanted to go to college, and he didn't want her to leave town because she wanted to go somewhere else. And she ended up getting pregnant, and she didn't go to college, and she carried a lot of regret about it. But so he wasn't particularly physically harmful or sexually coercive, but there was this level of coercion that prevented her from living her life the way she wanted to. So this is again about birth control sabotage. Women who have a history of physical violence have a much greater experience of interference with attempts to avoid pregnancy. And just tactics include destroying or disposing of contraceptives, impeding condom use, both emotional and material, not allowing her to obtain them, threatening physical harm to her or himself. So what we are proposing is what we call a brochure-based intervention. It's what that video referred to loosely. I'm so sad that you all don't have one of these in your hands, but they're available free of cost from our website, so I really encourage you all to mail out for some of them. It's called a reproductive health safety card, or a health safety card, and you can see in the bottom left corner it's designed like in an accordion shape. It folds out to be kind of a longish handheld card. It folds down to be about the size of a business card, and it's sort of made in the model of domestic violence kind of best practice, which is something that can be hidden quickly, easily in a shoe or in a bra or somewhere private, and really kind of goes into, did you know your relationship affects your health? It's designed, the text is designed kind of like a self-quiz, like a woman might find in a magazine. But it can also be used by a provider or to kind of as a screening tool, as a kind of cheat sheet. So the safety cards are evidence-based. We've been doing research on them for the past 10 years. They help in a variety of ways in terms of prevention. For victims who are currently being victimized, they help learn about safety planning, harm reduction strategies, and support services. For those who are experiencing something but aren't yet ready to talk about it, they plant some seeds. It's something to walk home with, something to talk to other people about. It also can work as primary prevention for folks who kind of are not experiencing it but can get to know the signs of an unhealthy relationship. And certainly, and we've seen this above all, it's an incredible way for patients and clients to educate their friends, peers, family members, and support people that they know and love. So by just handing it over and it's a very brief handoff. So how to introduce the card? If it was in your hand, you could really just hand it. We started giving this card to all our patients so they know how to get help for themselves or they can help others. Another option is we've started talking to all our patients about safe and healthy relationships because it can have such a large impact on your health. Creating a universal approach, just saying we're giving this to all the girls that come in here. We're giving this to all our patients. And I would encourage you to give it to men also. I mean, really, if you are going to be focused about it, giving it to women makes the best sense because it really is geared towards a women's audience, but men can benefit also just to understand the dynamics of healthy and unhealthy relationships, but really figuring out how to make it as universal as possible. So this Are You in a Health? One of the panels, the very first panel when you open the card, asks yourself, is for the patient, is my partner kind to me and respectful of my choices? Does my partner support my using birth control? Does my partner support my decisions about if or when I want to have more children? These are just indications of healthy relationships. It's a conversation starter. If she happens to read it while she's in this office with you, it's an opportunity for you to have a conversation. If you feel like you want to use this as a screening tool, this is just an opportunity for you to switch the pronouns. Is your partner kind to you and respectful of your choices? Does your partner support your use of birth control? So it's just this is where, the way that you can use it as a universal education tool. And, you can just hand it off to people. We really encourage you not to just leave them in the waiting room or leave them in the bathroom, because the best results out of this screening tool is when there's an integrated assessment that the provider is doing, that they're looking at the facial reaction or the response, or listening to the response, and they're checking in. Do you need anything more? Because that relationship building is really what bolsters the woman to see not only your clinic, but you as a provider as a true resource for their health. And the second panel goes into an unhealthy relationship. It's a more direct assessment specifically about reproductive coercion, but also more broadly about intimate partner violence. Does my partner mess with my birth control or try to get me pregnant when I don't want to be? Does my partner refuse to use condoms when I ask? Does my partner make me have sex when I don't want to? Does my partner tell me who I can talk to or where I can go? If any of these answers, if she responds yes openly to you, then we'll go into how to validate and kind of make a referral. But even if she doesn't respond to you, it's useful to kind of check in. Has anything like this ever happened to you? And then if, in fact, her partner does make her have sex, messes with or tampers with her birth control, there are options. Discrete methods of contraception, harm reduction, for instance, the IPV. And this third panel goes into that with a little more detail. I won't go into great depth about this, but if, in fact, a partner is that controlling where he monitors menstrual cycles, the copper T IUD would be the safest method, cutting the strings, but we know they're less vulnerable by tampering. We have heard cases in research where even IUDs are pulled out by a very abusive partner, but they're less detectable because they don't have it doesn't have irregular bleeding, etc. So if you do get a response of birth control sabotage, like, yeah, he poked holes in the condom, or he keeps trying to throw in my birth control pills, he won't let me use it. What you've told me also makes me worried about your health and safety in other ways. Sometimes when a partner is trying to get you pregnant when you don't want to be, they might also try and control or hurt you in other ways. Is anything like this happening in your relationship? This is that scary question. The yes, what do I do if I get a yes? And we'll talk about it right now. But this kind of scripting is really about bridging from reproductive coercion to the broader intimate partner violence question. And I want to encourage you to remember that our goal here is not disclosure. You're not trying to get that answer out of her. You're not trying to get her to leave him. The whole point is reducing her isolation, letting her know that you, as someone she trusts, you know that violence is not okay and violence is bad for her health, and you want her to be healthy. So if you're able to kind of just break through the isolation and give her information, then you have achieved your goal. The disclosure is sometimes, and it will be very, very rare, that you'll actually get disclosure. But in the case that you do, if you do have a positive disclosure, you want to begin with a validation, offering some of those discrete methods that are outlined on that third panel of the card, reviewing the safety card harm reduction strategies, and asking if she has any safety concerns that are immediate, like is he waiting outside in the waiting room, is there something, are you afraid to go home, etc. And then making a warm referral to a domestic violence advocate and following up at the next visit, following up to make sure she comes for a next visit, etc., things like that. The validating messages can be very simple and should really be authentic to you. Not everyone wants to say, I'm so sorry. So whatever works for you. I'm so sorry this is happening. You don't deserve this. It's not your fault. I'm worried about your safety. You're not alone. There is help available. And, whatever comes naturally to you, but those simple validating measures go a long way for survivors. Hearing those words, you could be the only person that has uttered those words. And so want to encourage you to think of yourself as having an incredible opportunity to make a big impact for women who are experiencing violence. You might ask yourself, does this actually make a difference? I want to remind you that even if she or he is not ready to leave the relationship, that validation is important. Like I mentioned, it reduces her isolation and shame. It encourages her to believe in possibilities. And with referrals and resources that you can provide, something as simple as like a private room to call the National Domestic Violence Hotline, or even just offering up your cell phone or the phone in your office, wherever, to be able to make a private call to get a little bit of counseling support can make a huge difference. Harm reduction is a form of empowerment. You can encourage her to think about all the kinds of assets in her life and how to get her friends and her allies and her family members who are supporting her to know what's going on. And first and foremost, to call domestic violence advocates. I can't stress enough the value of building relationships with your local domestic violence program. There are experts at safety planning in your community, people who know how to think about a woman's personal safety in a very strategic way. There are shelters available in all communities all around the country, as well as other services that are not residential services that women can access even if they are not using a shelter, like legal advocacy, support groups and counseling, etc. So do not underestimate the incredible breadth and wealth of resources available in your domestic violence programs. And I really, really want to encourage this. On the back of every single safety card, we have listed this National Domestic Violence Hotline. It's a national confidential hotline with numbers of people who work 24 hours a day, 7 days a week, and they have helped thousands of women. And just letting her know that she's not alone, she has someone to talk to anytime, anywhere, is an incredible resource. And I want to encourage each and every one of you to call the hotline. This is what that final panel looks like on the safety card. It's hard to give a good, strong referral if you don't know what's going to happen when your client or your patient makes that call. So I encourage you to call 1-800-799-SAFE. There are, amazing, skilled safety planning advocates available online. You can also go online. For younger clients, the National Dating Abuse Helpline is available at loveisrespect.org. They do chat-based support, as well as just a variety of other, like texting and all kinds of digital connection to provide support and information. And I encourage you to call just so you know what it's like. Similarly, I encourage you to find out who that person is at your domestic violence program, your local domestic violence shelter, that can be the advocate that you can call if there's a patient or a client that needs immediate support. Because the warm referral is the lifeline, is the lifesaver. And I want to draw your attention to this incredible resource, healthcaresaboutipv.org. At this website, you will find a huge array of resources for clinical practice, guidelines for women's healthcare settings, on how to better address and respond to intimate partner violence and reproductive coercion. In addition, a whole series of videos and training modules that are self-guided that can really help you think about how to best meet the needs of survivors in your client population. Tons of data and other kinds of presentations and resources that I know that you will find useful. And I want to reiterate that your efforts are not, the success of your efforts is not measured, like I said, by disclosure or the number of women who leave their abusive partners, but it's measured by our efforts to reduce isolation and improve options for safety. Normalizing the use of services in your community, whether it's domestic violence shelters, counseling groups, hotlines, normalizing the use of those services, setting a higher bar at your centers, at your clinics, and your community centers, setting a high bar for relationships, saying intimate partner violence is not okay, putting up posters, creating an environment in your centers that says we set a high standard for relationships and we believe that that violence is not okay. It sends a message to your population, and I really encourage you to go to creatureswithoutviolence.org, order posters, safety cards, and I mean pregnancy wheels, buttons. There's just a whole range of things that you can benefit from, and I invite you to explore. And I thank you for your time. I think we have some time for questions. This is my contact information. You're welcome to connect with me if you want to ask any other questions beyond the course of this training.
Well, thank you so much to Johnette and Sudebe for presenting today. The information was very helpful and informative, and we really appreciate you taking out the time to join us at this late hour for the East Coast. So what we will now do is move on to the Q&A portion. Just before we open it up, I do have just a few short announcements, but you can post your questions in the toolbar that is attached to the GoToWebinar software. You can just type it in the box, and I'll go and send it over to our presenters. So please use this as an opportunity to pick their brains and gain more information about ways that you can stop isolation and also improve safety in your communities. Please visit our website. We will be posting the recording of this, including the slides, on our website for future review. So visit nchph.org to get more information and resources. Also join our mailing list so you can be updated with webinars and some of the information we post related to health services, screening options, recommendations, and other pertinent information. Of course, follow us on social media. Even throughout the webinar, I was tweeting and posting some things that Johnette and Sudebe shared with us today. And so that's an excellent way to promote that through your communities and use it as a tool. And of course, if you have any questions or concerns, please feel free to contact anyone on our team in order to assist you. Just email or use that number below to contact one of us. So we will now open it up for Q&A, and as I said earlier, if you'd like to ask a question, please just type it into your control panel, and we will get that over to your presenters. First question, what kinds of, I think this is for Sudebe, what kinds of research has been done with the cards among male populations, or how has that been tested to show effectiveness?
Thank you so much for the question. This has not been tested with male populations, except in terms of when it has been tested with couples, like to show couples of the card and discuss sort of the general content, but not in terms of, because it's not written for men. It's written really, it is geared towards women and women's reproductive health. So where there have been some qualitative studies that have been done with couples where the male and female partner are sitting together and they discuss the card and discuss the content of the card, and it turns into, it's basically an educational session and sort of some feedback. That was in early pilots, but this was not designed for men. There is work underway right now to develop one that's kind of tailored more to LGBT MSM communities to be able to respond to that need, which is significant. But this work is specifically tailored towards women of reproductive age in heterosexual relationships.
Okay. And I think that was our next question is, how do, or is there a difference when assessing for IPV among a heterosexual couple or versus a homosexual couple or a bisexual couple?
Thank you, yeah, okay. I would say in terms of assessment, there is no difference. I mean, some of the specific questions around reproductive coercion might not be as relevant, or it may be actually. I don't think I can even say that. But the point is really getting at, do you feel safe? Do you feel like you can negotiate protection if you want, your safer sex or pregnancy, protection? And when it comes to gay relationships or sex between men or sex between women, I think that really what we're trying to get to is, do you feel safe? Do you feel like you get to make decisions about your own life? And how that power and control plays out. It plays out very differently with LGBT communities and MSM populations, because there's this added threat of being outed if in fact they're not out. So there's a lot of literature out there about intimate partner violence in same-sex relationships, which this presentation did not touch or cover, but it's available. A great resource is called the Northwest Network. Again, that's the Northwest Network. They're based in the Pacific Northwest. I can't remember if it's Oregon or Washington State, but they have really fantastic resources on intimate partner violence and same-sex relationships. I encourage you to check that out if it's useful.
Wow, great. Thank you for that. And then relating it to cultural materials that health care providers or some of those who work in social services can give to their clients or their patients that are specific to some of the cultural differences they face in intimate partner violence.
Well, I'll say all the materials that I shared with you today or described to you today are available in English and Spanish, and we're working hard on trying to get them translated. I think they're also available in Arabic, and we're working hard on getting them available in some other languages. They're not available in Arabic through us. They're available in Arabic through the Michigan Coalition Against Domestic Violence, just for the record.
Okay.
I mean, in terms of cultural resources, do you mean culturally specific materials besides language access, or maybe can you be a little more specific?
Just like with the card or with some pamphlets that are available to healthcare providers so they can include at their health center, are there any resources that you could recommend that are culturally competent?
Absolutely. Well, certainly the Spanish language materials we've produced are not just straight translations. They're kind of designed for a Spanish-speaking native, so it is culturally competent in that way, and it's been tested with Spanish speakers and studied that way as well. There are a variety of resources all over the country that are, that produce materials for in different languages, specifically on intimate partner violence. And I would encourage a kind of, if you're able to go to the national network to end domestic violence, there's this big national network that covers topics, all kinds of topics, and has a variety of different sort of subgroups that produce materials for specific communities. That could be an important way. And I would just encourage you to do more research. I'm sorry I don't have everything on the tip of my tongue.
Oh, no, that's fine. So what we will do for the attendees is, just for the few that you listed, or I can follow up with you later, we can provide a couple of links for them to check out other areas. Yeah,
I would be so happy to offer you, Rachel, just an email with a number of different links to great resources for any of these sort of subgroups, ethnic communities, marginalized communities that just require and make sense to have special materials for. I would be happy to share that with you.
Excellent, thank you. And then our last question, you mentioned reimbursement for IPV screenings. Can you discuss that a little further? Is there a special provision, like under the ACA, that people should be billing to, or how has that been working out?
Okay, so I can include this in what I send you, Rachel. So with the passage of the ACA, preventative care for women is covered, and what's new about that what preventative care includes is that it includes screening for domestic violence, which can be coded as just preventative care, and reimbursed. So I don't know the exact code for preventative care, but I would be happy. I know I have a fact sheet on it, and I could easily pass that on.
Okay, that would be great.
The population that's on the call. Yeah, absolutely.
Great. Well, we will go ahead and close our Q&A session, and I would just like to thank all of our attendees as well as our two wonderful presenters for joining us today on the call. As I said, this webinar is recorded and will be posted to our website following this session right now. And please feel free to contact us or the presenters for any more information or resources, but I will also include those resources in the email that I send to all attendees. So thank you to everyone, and I hope you all have a great day.
Thank you.
All right, bye.